Hi, my name is Alba Azola, and I'm a physiatrist. And I have the pleasure today to join you all and discuss long COVID in the pediatric population in this inaugural um, conference from A4P. I am a physiatrist with Johns Hopkins, and I also am part of the pediatric department, division of adolescent medicine. Very, very honored to be here today. In today's presentation, we are going to talk about the most recent epidemiologic data on long COVID. What are the risk factors? What predisposes patients to developing long COVID? We're also going to describe some of the proposed pathophysiologic mechanisms. Um, there's also going to be some discussion about special considerations that need to be addressed when we are working with the pediatric population of long COVID patients. So just to have the overview, back in the summer of last year, the National Academy of Science and Engineering met and created this um, beautiful definition. This is a picture representation of the definition, and they specified that this has to, in order for someone to get the diagnosis of long COVID, they have to have persistent new or worsening symptoms that have lasted for at least 3 months. It can be continuous, it can be relapsing, remitting, or progressive um, disease state that affects one or more organs. It's important to note that in order for somebody to have the diagnosis of long COVID, they do not have to have a PCR showing an actual infection. Suspected or probable infection is sufficient to give this diagnosis. Um, Also, the duration that they chose was 3 months. That differs to other definitions like the WHO definition, since some of the other definitions use the 2 month mark. The symptoms are varied and multisystemic. They have described up to 200 symptoms, and they can range from mild to very severe, with the impact and function that goes from mild to severe. So we can have children that are having difficulty in their competitive sports, but are able to continue doing practices, to children that are unable to continue in-person schooling and that have limited mobility. Um, and that is an important thing for everybody to understand, that it encompasses the entire range of severities. Now, the prevalence of long COVID in the pediatric population, we got our first report from the CDC in 2023 that estimated about a 1.3% of the population, of the pediatric population presenting with long COVID. Um, and those are patients that currently have long COVID. Now, those that may have had long COVID, but it resolved is a little bit of a higher percentage. But something to note is that in both cases, those who had long COVID and recovered, or those who are currently having symptoms, the prevalence is higher in the age group of 12 to 17-year-olds. Now, in 2024, we got the report from the largest national cohort from the RECOVER study, which was reporting on about 5,000 patients that they followed. And they found that the prevalence was about 20% in the school age population. So those that are 6 to 11-year-olds. And in the adolescent young adult population, they found that the incidence was 14%. So unclear whether this is more common on the school age versus the adolescents, but it happens in both, and it's quite prevalent in both groups. The risk factors for long COVID include a female assigned at birth. Um, Now, that is consistent with the adult presentation. Also, they identify risk factors of being older than 10 years of age. Hispanic race was another risk factor identified. Um, but it's important to note that other studies have highlighted lower socioeconomic status and immigrant populations. So, for example, in the UK, the Hispanic population was not a high risk, but in general, the immigrant population was at higher risk. Now, increased severe acute COVID definitely increases the risk of developing long COVID, and some comorbid conditions that put our pediatric patients at risk include allergic disorders, asthma, obesity, anxiety, any heart disease, and neurologic processes. Now, we don't have this data on the pediatric population, but based on the adult data, we know that potentially reinfections can be another risk factor for developing long COVID. On the recover paper that I mentioned earlier, published in 2024, they described two particular populations. So they were able to distinguish in terms of their clinical presentation, those that were 6 to 11-year-olds and those that were 12 to 17-year-olds. So the predominant symptoms were different. And they also were able to put together a long COVID score or long COVID index score, which is how they derived and determined which of their patients in their cohort actually were most likely to have long COVID. But the symptoms that were selected for the recover long COVID index are not necessarily the most common symptoms. These are symptoms that differentiate those infected that had residual symptoms and those that were infected by SARS-CoV-2 and completely recovered. So I want to bring the attention to this next slide because this is the one that has the most common symptoms in these two populations. So in the very school-age younger children, 6 to 11-year-olds, we had predominant headaches as their complaint. They also presented with trouble with memory and focusing, as well as sleep disorders. And a lot of them complain of abdominal pain. In the terms of the adolescent population, the presentation is much more similar to the adult population. Fatigue and daytime sleepiness, low energy is the predominant symptom. And uh, pain in the muscles and joints is also predominant. Headaches is a little bit lower, not as predominant as in the younger children, and also brain fog, trouble with memory and focusing. So, what is causing these symptoms? And the short answer is we do not understand this yet fully. We know a lot more today, 5 years later, from when the pandemic started, but we still have a lot of unanswered questions. So some of the proposed mechanism, and each one of this are gaining traction with new evidence from the research that's ongoing. But we know that viral persistence could potentially be one of the drivers of the long COVID presentation. There have been spike protein, which is a part of the virus, identified in people with long COVID, which is an indicator that there's active viral reproduction somewhere in the body. However, these viral reservoirs have not been completely uncovered and understood. the the evidence in terms of viral persistence. Um, it's interesting because even in those that had the SARS-CoV-2 infection but were fully recovered, we can also find these viral particles that indicate viral persistence. So difficult to disentangle what is responsible for symptoms and what is not. And the other point on the virus persistence is that trials utilizing virals as well as monoclonal antibodies have yielded negative results, not really showing a therapeutic impact. Perhaps it has to do with the length of the treatment or the monoclonal antibodies not being effective against the virus strain that has persisted in this particular patient. There's many issues to sort out, so it's very early on. But in terms of another proposed mechanism is post-acute inflammation, so a dysregulation of the immune system that is basically triggered by the infection. In some patients, there's evidence of a hyperactivation of the immune system. In patients that have had symptoms for longer and have a more similar phenotype to MECFS, we see an immune exhaustion or kind of a dysfunction of the immune system from that are unable to combat or suppressed immune system. We also have evidence of autoimmunity. There's been identification of autoantibodies against the autonomic nervous system and a hyperactivation of B cells that produce these antibodies. So again, some rising evidence that it is, but also treatments like IVIG and plasmapheresis have yielded kind of different results, conflicting results. So unclear whether this treating the autoimmunity component is going to be curing this. So again, I just want to highlight how early on we are on finding the root cause of the long COVID presentation, thrombosis, the proposal of platelets or microclots in this patient population. Those have been identified. There are ongoing trials with medical interventions, medications that can break up these clots. We're still trying to understand how this plays a role and how the potential for intervention and improvement of symptoms could be an area. Reactivation of viruses, there is clear evidence that people with long COVID often have reactivation of herpes viruses, including EBV, varicella zoster, herpes 6. However, the role of antivirals or administering antivirals has not yielded a positive response in terms of symptom control. There's also potential for the gut dysbiosis to be contributing to this and mitochondrial dysfunction. And again, I could go on and on about each one and the level of evidence that has supported that this is what potentially ongoing. However, that tie to the symptoms, it's still unclear. And perhaps because of the broad presentation of patients with long COVID and the different symptomatologies and multiple systems involved, there may be more than one of these potential pathophysiologic mechanisms interacting in one given patient. So also trying to identify what is playing a role in which patients can help us find how certain treatments will yield a better response. You know, if we can identify which patients have a particular mechanism ongoing. So when we are assessing a patient, a pediatric patient with long COVID, it's really important to focus on the functional impact. Are they being able to complete schooling? Are they being able to consistently participate in their after school or extracurricular activities? Um, and we also want to think about the patient and what is most important to that specific patient. What symptoms are most debilitating to them, and what symptoms are more treatable, and which ones will need subspecialty referral. Um, we also want to ensure that the patients have a safe space where they feel validated and they feel comfortable disclosing their symptoms and what their body is experiencing. We also think that it's important to help these patients navigate the healthcare system and the complexity within it. And this is another point why we think that physicians treating long COVID, we should have a quarterback on the care of this one patient, because many times this patient's care are fragmented given the multitude of systems that are involved and different referrals to different specialists. So it's important to have somebody that ties it in together. Um, it is important to also support coping of the changes that these patients are experiencing. So psychotherapy can be extremely helpful, just like it's helpful for patients that have a new chronic illness of any kind. Children that start presenting symptoms of diabetes, or patients that have a traumatic brain injury. Those patients that develop impairments, they need the tools to be able to um, cope with their changes and the different ways that they have to live their life. And it's really important to remember that this loss of function causes a decrease in the quality of life, and it can lead to depression and anxiety. And in particular, in the pediatric population, we have to think about how these impairments are going to affect the typical milestones of school-age children and adolescents, and in particularly in the context of their social interactions. So there's a lot that these patients need support with. Now, I wanted to highlight that in long COVID, not all fatigue is created equal, and we want to pay special attention at how the patient describes the fatigue. We want to be able to identify if there is post-exertional malaise. And this term is not very descriptive, but there is a specific presentation that really um, cinches in the presence of post-exertional malaise and differentiates from other fatigue presentations. Now, why is this important? The treatment for patients with post-exertional malaise is very different, and it should be approached differently than other types of fatigue. When we talk about post-exertional malaise, we talk about an exaggerated response and a flare of symptoms to an inciting activity that used to be well tolerated. So this is not just doing an activity and feeling tired while you're doing it. This is actually a physiologic response with a flare of a multitude of symptoms triggered by an activity that was easily tolerated. Now, the most common symptoms in post-exertional malaise include severe exhaustion, worsening brain fog, pain, typical myalgias appear, difficulty with sensitivity to light, sensitivities to smells, um, sore throat. Some of them feel like they're coming down with a virus. Sometimes they may feel even feverish or get chills and feel like they're coming down with the flu. So it is really a large number of symptoms. And what we observe in patients that have a post-exertional malaise is that they enter this push-crash cycle. They feel good, they do a bunch, and the next day or hours after a day where they overexert, they end up crashing. And usually the crashing involves a very limited activity tolerance, and all of the symptoms coming up. And as the patients continue to ride this corona coaster, which is my preferred term, they continue to feel better and then crash, have a couple of bad days, and do it all over again. And repeating this cycle actually, uh, what it ends up leading to is a loss of function. So it's important to learn that we need to step out of the corona coaster and start learning to manage our energy envelope and pace so that we're not continuing this push crash cycle that leads inevitably to loss of function. So how do we do that? We discuss strategies like the 4 Ps of energy conservation, learn to pace, to make decisions regarding what activities are going to be done in a specific day. For some kids, that may look like deciding that they're going to have to give up one of their sports or um, extracurricular activities and figure out which ones are more important to them. And that's the other P of prioritizing. What are the things that are non-negotiable and which activities can be more limited, and that way we're not often going over our energy envelope limit. Planning around activities, making sure that we're prepping with hydration, rest prior to an exertion, and also how to, for example, control environmental things that are triggers like heat, and bringing cooling garments, or um, how to dress. So planning, it can be super helpful in allowing patients to do more. And then positioning, what are we going to bring when we're going up the stairs? How many times we're going to go up and down the stairs? Can we minimize that? Can we accommodate things in the room so that are easier to access, less energy expenditure? Other things that physicians can provide for patients are access to durable medical equipment. And in the case of teenagers that are driving, a parking placard that allows them to go to different places, but also limit their need to walk long distances that can be further fatiguing. Also, it's important to provide reasonable school or work accommodations. This can be as simple as allowing the patient to have water during class, allowing the patient to go to the bathroom more times, allowing them to sit in a different way, to um, a lot of this patients get in trouble for seemingly being squirmy or kind of not being able to sit still, but it's actually their bodies trying to compensate for their orthostatic intolerance. So teachers should be aware of this, and they should have accommodations that allow them to do that type of modification. Physical and occupational therapy can be incredibly helpful. However, it needs to be done by providers that fully understand what post-exertional malaise is, given that in patients with post-exertional malaise, um, again, over exerting themselves can lead to worsening flares and symptoms, and again, getting into that push crash cycle or corona coaster. And I highlighting again the role of rehabilitation psychology in helping with the coping skills needed. Um, these are some examples of accommodations. If their mornings are really difficult for them, perhaps they can have a schedule that allows them to do more a later start, flexibility in the assignment due dates, allowing them to not have to push too hard and go over their energy envelope. Also, flexibility in absences and ability to drink fluid and use the bathroom as needed. Um, It's important when we talk about long COVID that we acknowledge that some of the phenotypes in this patient population are very similar to MECFS, and it's important to assess all the potential comorbid conditions that contribute to the fatigue. And this diagram is from a paper we published in the Pediatric Clinics of North America, summarizing our approach to long COVID. Um, it's meant to be accessible for is open access for patients to look up and be able to bring that literature to your primary cares to help them guide on how to manage and identify um, potential comorbid conditions that need to be addressed. Um, and this is more for clinicians, but again, on our paper presenting the approach to long COVID in the pediatric population, we highlight the parts of the physical exam that are important, as well as laboratory work that should be done, and the importance of orthostatic testing. And orthostatic intolerance, which I probably mentioned a couple times, some of you may be familiar with the term, but basically is a group of clinical conditions where symptoms appear when the patient uh, and engages in an upright posture, like sitting or standing, and those symptoms improve when the patient lays down. And usually they can persist a little bit, so it takes some time for those symptoms to get better, but definitely are triggered by being upright. And the physiology, which you probably have seen in a different topic, includes this concept of blood pooling in the extremities and at the abdomen as well, decreased ability to vasoconstrict from dysfunction of the autonomic nervous system, and an overall decrease in blood volume. When the person moves to a standing position, the blood pools, there's limited blood flow to the brain, and there is a ringing of the alarms from the brain, which is a sympathoadrenal response. It's a fight or flight response that is basically your brain ringing an alarm. I'm not getting enough blood. Let's make the changes needed. So at times, this can present with different types of autonomic dysfunction profiles. So POTS is very common, but it doesn't mean that if a person doesn't have POTS, doesn't meet criteria, those 40 beats per minute threshold, it doesn't mean that they're doing okay. We actually have growing evidence that even in patients that don't have hypotension or other changes, that have completely normal heart rate and blood pressure, those patients can also see a decrease in the cerebral blood flow. So that's the main point here. Just because the patient doesn't meet the criteria for POTS doesn't mean that this is not occurring in the patient's body. Now, some of the symptoms that are most common include lightheadedness, shortness of breath, syncopal episodes. There's definitely a chest discomfort, which sometimes can be very scary because it feels like you're having a heart attack, and the sensation is very similar, but it is actually just part of the response and the fight or flight response that is triggered in this abnormal or dysfunctional autonomic nervous system. Orthostatic headaches are common, palpitations, this feeling of anxiety without a particular reason um, sometimes comes up. And I explain to my patients that this fight or flight response is it's one of our most precious responses. Is there to preserve our function and our survival. For example, if you were in the middle of the woods and you had a bear bite your leg and you were losing blood, you want this fight or flight response to be turned on to allow you to um, be able to leave this situation. However, in a person with autonomic dysfunction, this response is being triggered inappropriately. So many of the patients describe the sensation of something really bad happening or anxiety that is um, inappropriate because there's um, no situational reason for them to have anxiety. Um, The stand test is a very simple in-office way to diagnose patients. Um, I think it's something that can be done with minimal technology, just a blood pressure cuff is sufficient. And it's important that they not only look at the changes in heart rate and blood pressure, but also note the symptoms. Are the patients feeling lightheaded? Are the patients starting to breathe faster? Looking at their legs without shoes on, is the blood pooling evident when you look at their legs at 8 or 10 minutes standing? So it is more than just heart rate and blood pressure, but there's also a component of observing for symptoms, of asking about changes in the severity of the symptoms, that is important in the diagnostic process. Um, so key points is that many of our pediatric patients present with long COVID. Initially, we were thinking that it was not that common, but the evidence, especially the newer evidence, is showing even higher rates of 10 to 20% of those infected with SARS-CoV-2 develop long COVID. It is important to note that we can use tools and we can use the knowledge from um, MECFS, or myalgic encephalomyelitis chronic fatigue syndrome, and apply that into the treatment and assessment of this population. And orthostatic intolerance, which is almost universal to adolescent and young adults, is a very treatable condition. And I'm sure that you have heard about the non-pharmacologic and the pharmacologic interventions. I addressed those in another talk that I gave for this conference. And there are certainly tools that not necessarily require a physician to start implementing and that are important. So lastly, I wanted to make the point of checking for those comorbid conditions that are common in this population. This long COVID doesn't affect a random group of people. These are people that have certain comorbid conditions. Many of them are hypermobile. Many of them have allergies, milk protein intolerances, exaggerated allergic response associated with mast cell activation syndrome. So it is really important to have the children assessed for all those common comorbidities. And I have some more resources that you can share with your primary care physician, including this primer on management of MECFS, um, uh, the book from Peter Rowe, A Guide to Diagnosis and Treatment, Living Well with Orthostatic Intolerance. He's a pediatrician that has dedicated 30 years of his professional life to studying and treating this patient population. Also, with the Academy of Physical Medicine and Rehabilitation, we have published multiple manuscripts, including this manuscript on the management of pediatric patients. And the paper that I discussed, some of the slides came from, which is the uh, review of the management of long COVID in adolescents and young adults and the implications and considerations for that particular group of patients. And I just want to thank our clinic, all the funding, and all the families that are grateful and have helped fund our clinic and keep our doors open and continue to learn more about this clinical presentation and the best treatments. And you can follow us on Hopkins MECFS-C. And that's all I have. So thank you so much for having me, and I hope you have a great rest of your conference.